lot of this, a lot of these techniques follow real closely along with the as normal as possible, as much as possible process for all classes as well too. So kind of keep that in mind when or like doing some of these kind of funky and specific things. Like this transfer is like, okay, like, well, why are we being so specific with this type of transfer here? Because everything is that we're doing kind of designed in a way to incorporate the use of the involved side as much as possible, and get it doing things as normal as possible too. We don't just want it, we'll make this involved side now. We don't just want all of this stuff going along for the ride. We want to give it a job, give it something to do, give it a chance to return to normal function. So we want to incorporate it as much as we can, force him to use it as much as he can in like as normal ways as possible. Because realistically, I could pull this chair up and you could probably transfer into it without using anything over here at all. Go for it. Yeah, there we go. He got there, and on his own, but that left side didn't do a thing. It just slid along, went along for the ride. Didn't incorporate it into use whatsoever. It's never getting better that way. So we want to teach you ways to become able to get this side returning to function. So our really two transfers that we're going to do are stand pivot transfers and low pivot transfers. Low pivot transfers, I feel like we're going to go over first because it's a lower level activity. It's for somebody who it's not safe for you to, or you're not able to stand all the way up and transfer yet. You don't have enough return here. You don't have the balance necessary. You don't have safety awareness, to stand up, take a couple of steps and have a seat. So we'll do a low pivot transfer. Still going to incorporate this side into use as much as possible. And you really want to take the time going through this process with your patients and just let them sling themselves over into that chair. So when you first do it, it takes a little bit of time, like kind of teaching them the process. We'll be going in the direction of his uninvolved side, which is going to be an easier transfer to make. But then we'll go the opposite direction. The setup's going to be exactly the same either way. It's going to be easier to transfer to your uninvolved side, harder to transfer to this side. So you really get into all the same positions we did as transfers before in the fall. The patient has to scoot forward, their feet have to be back and underneath them, and they've got to lean forward and initiate the movement. So none of that's changed. A little bit different handling since it's the person who's had stroke. We're really specific about our handling. So lower level people are probably going to asymmetrically scoot forward. He can bring his uninvolved side forward, no difficulty. This one, a lot of times it can't. So to get that forward, we do that lateral pelvic tilt, and then I give a forward and downward pressure. So I'm pushing down into his knee, down through his leg. He's bearing weight down through, and I'm bringing that forward. Because that's what you normally would do. So scoot back, if you were gonna asymmetrically scoot forward, which I know is not what you do, you push that foot down into the floor and pull yourself forward with it when you scoot this forward. So you can do that on your own. That's the normal movement, so that's what my hands are doing there. Scoot back, and you can bring that side forward again as you did, and then you get our lateral pelvic tilt, a downward and forward pressure. I don't hear our don't have to slap your person. Yeah, but a downward and forward pressure, because that's what you would normally do in that situation. So I don't want to scoot this one forward. I don't want to lift this leg and pull it forward, because that's not how. If you were to, when a human scoots forward asymmetrically, they don't lift their leg up and push it forward, they pull themselves forward with their foot on the floor. So that's what we want to replicate. Bring this one forward. It's always easier to do the unfall side first. We're gonna do a lot with our shoes off, so just get used to that. We'll do a lot of that next week as well too. Gonna turn your ankles towards where we're going, and I'm gonna face where we're going to. So once we weight shift and unweight your behind, you're kind of already deviated that way too. You're already kind of going that way. You always break down this transfer into a couple of different steps. So we can do 45 degrees and another 45 degrees. Hold the knee at the butt to lower this down here. Just so I get our surfaces even. That way it's not just like slinging all the way over, and it gives them like 2 opportunities to do the whole thing. They go here, 45 degrees at a time. You always want to say you're going to lift your behind up about this far. So many times you get patients like, oh, spend all this time getting set up, scoot forward, great, get your feet pointed, and then they stand all the way up. I'm like, okay, that's not what I was planning on doing. Yes, we're up. And then there's like leaning on one side, and they let go of this one, and they reached out for this, and they did all the things you told them not to do. I'm angled to where he's going. My chair is pointed towards where he's going as well too. So I want him sitting up nice and tall and anterior pelvic tilt. That's what my hands are doing there. Just got big